Schilinger.
Morning.
Good to have you today.
Likewise. Glad to be here.
Yeah, absolutely. So we talked a little bit about what we have been doing with this web series in terms of like kind of just having conversations about people's experiences, their beliefs, and their views surrounding drug use, drugs in general, and kind of the approach that we as a society have to those subjects, the stigmas around them and all that. So, we've talked to various people about those experiences, but we've yet to talk to a physician. So, I know that you've kind of helped out as far as like the FLASH program, Rebel Recovery Syringe Exchange, on some of that stuff. I've gotten to know you a bit through that, but I haven't had like a real long conversation with you about, some of your beliefs and how it is that you got involved with the recovery community down here. So I guess we can just start off with that, maybe, what was kind of like your first experiences, not necessarily with drugs, but like learning about drugs, or like the kind of the thing that maybe implanted your own views on drugs and drug use, like that you could maybe remember?
Well, it's an interesting question that you would bring up. My personal perspective actually was probably pretty stigmatized. As a young person, it was something that I thought I didn't want any part of. Mm-hmm. Growing up in the 70s and the 80s and going to college and medical school in those days, there was a lot of stuff going on. And I was really not any part of that community. And I felt kind of like as an outsider, but it wasn't something that was attractive to me, but I kind of felt like I missed out on a lot of friendships. I remember even once in college, there was a girl I met who was thinking of asking out, mm-hmm. and people go, "Oh, no, she's not for you." Kind of like, because I was always labeled as a guy who was not part of this drug scene.
Right.
So I kind of grew up in that sheltered perspective. So I definitely, I think, stigmatized people with that. It's like, oh, lock them up, let them rot. Who cares?
Mm-hmm.
I think I had that kind of attitude from years ago. Now, you asked more recently what got me involved in these things. As a physician, I'm a dermatologist, mm-hmm. so I'm not an addiction specialist per se, but I'm a physician. Right. And I spend a lot of times doing things outside of my specific specialty, what I would call healthcare advocacy.
Okay.
It's something that I kind of learned that I really liked doing over the years, particularly through organized medicine, starting with locally Palm Beach County Medical Society, going on to the state Florida Medical Association. There's a lot of opportunities to bring people together. There's strength in numbers. When we bring a bunch of doctors together, we can make a difference. Specifically in terms of drugs and the opioid situation here locally, it was kind of just by accident about 4 or 5 years ago. I went to a continuing medical education program one evening, and it was called Town Hall on Opioids. And I think I went because it was like free dinner and an hour and a half.
Sure,
credit.
yeah.
And I went there, and I heard a presentation on what the healthcare district and JFK Hospital was doing, a pilot program they were doing on bringing people who come through the emergency room, putting them on some type of special program and looking at the data. And I found that really kind of interesting. And as a physician who's always looking for opportunities to get involved, to do things where I can make a difference, just cause for selfish reasons, it makes me feel good if I can make a difference. I said,
I get that.
This sounds kind of interesting, right? So I reached out the next day to Dr. Andrick, who is the chief medical officer at the healthcare district. And she actually wasn't there at the meeting. And I called her to tell her how impressed I was with the presentation. Mm-hmm. And I said, what can we as a medical society do to help further the whole direction that you're taking things and helping people? So that kind of opened up the door. Right. We then had another meeting the next week and a meeting the week after. Then there was shortly thereafter, coincidentally, a meeting up at the VA hospital called for by Congresswoman Lois Frankel. And there were about maybe 15, 20 people sitting at the table. Influential medical people from the local community, and also different aspects. I think myself, maybe one other physician was there. And Lois, she says halfway through, she goes, well, what are the doctors doing about this? right? And she's kind of looking right at me. So I jumped in and I made a commitment. I said, well, the medical society is going to form a task force specifically for the people in healthcare, specifically for the physicians, so we can get them to better understand what's going on and help make some direction, make some decisions, set up some parameters here. So that kind of by accident, I was in the right place at the right time, or it was meant to be. It was some type of destiny. And of course they said, well, then you can chair that committee.
Yeah. So was that task force planned up to that point, or was that literally like a idea that happened in that moment when she
kind of a
asked you?
spur of the moment thing?
That's cool.
I had been discussing this with Tenna Wiles, who was the CEO of the Medical Society. Recently she retired, but we've been working together for 20 some odd years. And she thought it was a great idea. We didn't know exactly where to take it. Lois had this meeting, and out of that meeting we said, now our spot is defined. Now we need to figure out exactly what we're going to do, but we made the commitment right then and there that day.
Gotcha. So the JFK program you're referring to, just so I have an idea, I'm thinking it's the medication assisted treatment program.
That's what that was.
Okay, so basically somebody, for people who don't know, somebody who came in coming in from an overdose, or I know like now they can just, if they're dope sick, they can just come in and then get dosed with buprenorphine, Suboxone. And if I'm not mistaken, during that pilot program, there would be somebody who would bring them their dose for like the next 8 days, I think, until they were able to get into like an outpatient program around the county.
Yeah, I don't remember all the details, but I know there was peer-to-peer counseling, and it was it was a very well organized program with a small number of patients in the pilot. And it was certainly an interesting first step to see that things were really being done here in a county that was considered by many to be kind of the epicenter of the opioid,
especially at that
crisis.
time, for sure.
Exactly.
Being treatment center capital of the world at that time, there was a lot of people around the area kind of doing the South Florida shuffle, they call it, in and out of treatment centers with the whole insurance thing, and definitely raised overdose deaths in the county, for sure. So where did it go from there? So you guys essentially started the task force at that point or in the months following with that group of physicians?
Yeah, shortly thereafter, we identified interested individuals, including physicians and community members, to be part of a small committee, which we called the Opioid Healthcare Response Initiative. I didn't want to call it another task force. I said, let's call it something a little bit different. Let's make a commitment to actually do something rather than just talking.
Right.
And from there, shortly thereafter, we sponsored a half-day symposium, which was over at the conference center by the Hilton, by the airport. And we had a lot of different aspects we took a look at that day, but we modeled a lot of that out of the work that was done in Rhode Island. We did our research, and we found, well, Rhode Island is a state about the size of Palm Beach County, a population about the size of Palm Beach County. They're having similar opioid problems, and they had been a leader in this, and under the governor at that time, Governor Raimondo, I believe. They had set up a pretty comprehensive program, and we spoke to them extensively. We actually had a couple of doctors who had set up that program come down and speak to the group on that Friday morning that we did the conference in West Palm Beach. And what we defined at that point was that there were 4 different directions to go within our initiative. And that would be prevention, rescue, treatment, and recovery. Just the beginning of looking at something that's so multifaceted and so complicated. Every door you open up is like 10 more doors in there, and so much to be done. But we started with breaking it down into those 4 aspects. Then we hired a facilitator. This is a man who had helped us at the Medical Society about 20 years earlier, set up a network, the Health Emergency Response Coalition, which has been very effective, and we've been a model for the whole country, which came after the 9/11 anthrax poisonings, which of course, Palm Beach County is always the epicenter for something or another. So they found the anthrax here back in 2001,
Yeah.
shortly after 9/11.
I remember.
And we had to bring, so as a medical society, we brought together all the different hospitals that oftentimes didn't talk to one another, got them all on the same page. So the fellow who had helped us facilitate that almost 20 years ago, we brought him in to help facilitate an action plan for our opioid initiative.
Okay. All right. So most of that probably, I imagine, like involved, in terms of the rescue portion, like overdose response, and then the implementation of medication-assisted treatment programs. Is that?
Well, that's a good point that you bring up.
Yeah.
Because I try to listen to all sources. I like to say that I'm not an addiction specialist, but I don't have that bias that an addiction specialist would have.
Okay.
I'm a physician.
Yeah.
I have the compassion. I've chaired the ethics committee for the county and the state medical society, so I have a lot of interest in doing the right thing, but I want to listen to all parties involved. So the MAT area is really kind of interesting, because one of the first public town halls that I attended, this was over at Palm Beach State College, shortly after our coalition was formed. There were a lot of people speaking. There were a lot of people in recovery in the audience speaking out vehemently against this MAT thing. And I'm like, well, why are the doctors pushing this so solidly? And why are so many people in the community so against it? So I noticed that from an early stage, this is an area where we need to have some dialogue at the very least.
Definitely.
And as a physician, I was sensitive to hearing what people who have been through this personally had to say. I think that's pretty significant. And it's still a dialogue. Okay,
Yeah,
it's something that I'm not quite sure what the answer is. You've got people on both sides who are extreme. You've got people saying that's the worst thing in the world. You're taking people off a drug and just putting them on another drug, and they're still addicted, and it's going to be horrible, and they're going to be on this the rest of their life. And then you'll have others who will tell you that they find a person who's really dysfunctional, who's kind of looks like a dreg of society, so to speak, not to be judgmental, but they put them on Suboxone, and like a week and a half later, they're highly functioning and everything is great.
Sure.
And I've heard that from multiple physicians. So you hear this and you go, well, there's got to be something to this as well. So I would say from early on, even the first meeting that I attended, the one about the review of the healthcare district JFK thing, there were a few physicians in the audience who, incidentally, I found out after the fact, are physicians who've been in recovery, who at that point were very much opposed to thrusting MAT on everybody. So I pay attention to that, and I wouldn't say, I'm still on the fence, trying to listen to all sources. So it's an area where we will continue to explore. I think part of what we've done with the initiative in the medical society is copying a phrase they had up in Rhode Island, which is all doors are open.
Yeah.
So we have to consider the individual and see what's best for a given individual. My bias at this point is probably not everybody is indicated for this, for medication assisted, but maybe a lot of people are, or maybe we need to develop better algorithms so we can get the buy-in from everyone involved.
Right.
So I walk away saying it's certainly complicated. We don't have all the answers yet, but we have to look at data, and we have to also understand people's feelings and the emotional charge that comes into all these issues before we pass judgment.
Yeah, there's a lot that goes into that, right? And I think the important piece, at least initially, is like starting to have those conversations and be able to have those conversations. My experience is, and it's not surprising what you just told me, but I think it's very interesting as far as like that dividing line between those people in recovery who are speaking out and the physicians who have maybe seen like the effectiveness or a potential effectiveness of medication-assisted treatment. And like where that line kind of falls, that doesn't surprise me. It's been my experience, and I would venture to say a lot of people's experiences that identify as being in recovery, that people in recovery often tend to not to generalize, but have more potential of being just as, if not more, stigmatizing than people who have never had experience with substance use. Having gone through like a substance use disorder and experienced chaotic use, and then somebody coming out and finding their path, oftentimes, for whatever reason, you could dive into that and have a whole conversation on that alone, but the other paths, they stigmatize, more so than maybe somebody who like doesn't have any experience at all whatsoever. So if somebody did come into recovery and took like the abstinence-based approach, went through a 12-step fellowship, or didn't, just like was abstinent, and that was the way for them, it seems like it's a pretty common pattern to like kind of speak down or look down upon the other side. As far as like evidence goes and the data, there's certainly a lot to be said for medication assisted treatment. I mean, you'll hear like a lot of physicians say that it's the gold standard of substance use treatment today. It's hard to gauge like rates of success and things like 12-step fellowships, but I would say like putting them against each other, I would say MAT has the upper hand, just pure numbers, but there's a lot that goes into that. And I think like that's why it's so important to have these conversations, because of the fact that some like people that are on MAT and find success with MAT are well aware of the stigmas that they face. They're like less likely to be outspoken about that, at least in my experience. And that's, something that I've seen, in that even the people in the rooms of 12-step communities that are maybe like around abstinence-based recovery will keep that under wraps because they know, the stigma that they might face for being on MAT or having utilized MAT. Medication assisted treatment saved my life, and more so than that, like it gave me a life, and absolutely it's not for everybody. I know people who it's not even just like the whole replacing a substance with another substance. It's really my belief that it comes down to like with any substance use, like your relationship with that substance, and there's certainly people who, no matter like what it is, they're not going to have a positive relationship with even Suboxone or methadone. But it does seem common that they kind of may project that I can't have a positive relationship with those substances, so like nobody else is going to either. And then it really does, like you were saying, like it becomes like this heated debate because people, it's saved their lives, they've watched it save other people's lives, and then other people, have their own experiences or just really deeply ingrained biases like against that. And I get it, like I say it a lot when this subject comes up, but if you think about like 12-step fellowships, and it's not a religious group, but in the same way that people who follow religion feel that, and this goes back since like the beginning of civilization,
Sure.
that this is what saved their life, and people have for years killed each other because somebody else believes in something different that they believe saved their life. In the very same way, I view that as how people from, maybe either side come about it. But it seems to be very deeply ingrained in like those communities, 12-step communities, like this is the way that I took. And whether it's like a feeling of being threatened that somebody else may recover differently, or it's just, I couldn't say what it is, but I definitely think it's that same line of thinking. Like this saved my life, you're doing it differently, that's wrong.
Mm-hmm.
And, I see that a lot, and I've seen people hesitate to, take another path, and they try this same thing over and over, and they don't want to take this other path. And, it can be difficult because I'm also all about like, what do you feel is best for you when I'm working with somebody, or even like talking with a friend and trying to help them through something. It should be about the individual, like you were saying, and everybody should have their autonomy. But where is autonomy versus like the influence of stigma and, all that comes into it, and just like not being willing to do something that potentially has, the ability to really help somebody just because of the stigma that they've faced.
Sure.
So,
well, it's certainly a dialogue that I look forward to continuing.
yeah, it's important.
I see myself as kind of a facilitator or mediator, kind of Switzerland coming into the picture. Let's be neutral and let's look at what's going on here. But I've heard the bias from physicians who've done a lot of work in the area, but they come in with this, well, anyone who doesn't agree with me is just stupid. I mean, I've heard doctors say that, and I go, well, maybe there are other options.
That's not.
Then you hear the guys who are traditional 12-step guys saying, this is terrible, you're just putting another serious drug in your body, and now you're addicted to that, and it's horrible. And clearly, it's based on, like you said, their emotional bias that they have, and the answers is somewhere in the middle, not necessarily exactly in the middle, maybe a little bit more here, a little bit more there, or a lot more one way or the other. But it goes back to that phrase that we brought in from Rhode Island, all doors are open. We seriously need to do that. One of the other challenges, just talking about the MAT arena, is I think in a lot of scenarios, you have the M and the A, but not the T. You got the medication, but you don't have the treatment, you don't have the emotional support. And without that, it kind of works sort of, but it's not really taking it to the fullest benefit. So that's an area. Then it all gets back to funding for things. It's like, who's paying for this stuff here? So the medication tends to be inexpensive, right? But the treatment and the therapy is another problem.
Absolutely. I've seen in my own experience utilizing like CEFBIN funded outpatients in Palm Beach County, like a little bit of both. I've had some good therapy and mental health, access to those options, but other times, even in the same place, like not so much, and just like depending. But there definitely could be more available for people. And we were kind of talking off camera, you mentioning like the telehealth side of things, which comes in a lot now after, COVID, but it really, looking back, like could have been utilized more so beforehand. Is that,
Yeah, and I think moving forward, people are much more comfortable with the whole concept. Like I said, every person who suffers from addiction owns an iPhone or an Android. Mm-hmm. So they have this tool right in their pocket or in their pocketbook that can be an entry point for behavioral therapy. And as you just referenced, the MAT without the therapy is probably one of the reasons that people on one camp are quick to put it down. It's because, you're just giving them a pill. Well, if you're taking some medication and you're getting all this emotional support, mental health support, I think it takes it to a much higher level. Although to confuse matters, we have so many crazy things published, at least in the medical literature. I think there was some study that came out that said the behavioral health component didn't actually make a difference with MAT.
Interesting.
I don't know. My gut says I don't agree with that. But you can make data say anything you want these days.
That's definitely
they do what
true.
they call meta-analysis, and I laughed at this when they started that years ago. And they'll do that with any topic,
analyzing data
in medicine. Let's look for 100 studies that support our position and publish a paper saying, look how much data we have.
Right.
But they always ignore the studies that don't support their position. There's a group called the Cochrane Board that supposedly has oversight on a lot of these meta-analysis studies. And there was a problem a year or so back, and half of the board members resigned because they didn't agree with the decisions that the board was making. So data is a tricky thing in terms of knowing which way to go. But again, I go back to, I think we need to consider all options. We need to continue the dialogue. I'm a strong proponent of bringing people with different perspectives together, because when it comes to the opioid epidemic, the opioid use disorder, and the patients, the individuals who are involved in this, everyone has the same end goal.
Right.
And the end goal is to put people in a better place than they are.
Right. Absolutely. I mean, that's recovery, right? Like recovery isn't, we were talking a little bit off camera, recovery isn't defined by abstinence of a substance, what I do or do not put into my body. It's defined by, living a self-directed, fulfilling life, taking steps forward. Like I have maybe a different view than a lot of people on recovery, but I certainly think that it's easy for most people to grasp that it's a spectrum, and it's not one thing. At least I hope that's easy for most people to grasp. But I take the position that like somebody making one decision, such as like they're reusing syringes every day, or they're sharing syringes every day, and then make the decision to not stop, but to only use a clean syringe every time they inject. In my eyes, that's a step into recovery. That's the recovery process right there. And that's starting, and, that's an esteemable act. Recovery builds on esteemable acts. And I think like those things are important to consider when we kind of are trying not to look at recovery as this like one definition, and that definition being abstinence or not. But back to the MAT thing. Kind of on that same end, I really think that I agree that for a lot of people, like that treatment side and the therapy mental health component is very important. But again, like it goes back to each individual, and you're totally right that a lot of like those like meta-analyses, and there's a lot of like studies that just kind of like end up like biasing towards their own, views and beliefs, or what they really want to find with it,
So we have to be careful when we look at it. And sometimes, even though in scientific circles, anecdotal reports are frowned upon, but yet I think gut feelings and anecdotal reports can be very significant. So I don't think we want to ignore that completely. But you mentioned with MAT and the behavioral health component, I think regardless of the approach, to have true success and to meet the definition of recovery, people are looking for purpose and functionality in their life. So I read an article years ago where they were just looking at the various psychiatric medications. You can give somebody this so they're less depressed, give them this so they're less anxious. But to get to a true recovery state, they have to be reintegrated into society. I mean, we're human beings, we're social creatures, we like to interact with others. So that's where people really need to be ultimately. So I think that also becomes part of the whole program, giving people a reason to get up and get out of bed in the morning, to have something specific to be doing, to feel good about. It sounds very simple. It sounds very trite perhaps, but it's so critical in the whole process, I believe.
Yeah, I think that's the key, really. And I would venture to say that at least for some of those studies, like maybe that's really where it's pointing towards, in terms of like, it's not, so referencing like Portugal, like they legalized or decriminalized all substances. Yeah. And because they had a huge problem, and to the extent, I think it was like 1 in 10 people were addicted to heroin in Portugal, something outrageous like that. But Carl, if you can Google that. But regardless, like they had a big problem and they needed to solve it. So like they, got a group of scientists together and asked them what they should do, and then went all around the world, studied different areas and different drug policies, and came back and said, you need to like decriminalize everything. And they did, but the key was putting all of that funding that they put into criminalizing people for using drugs into not so much treatment. Like there was a treatment component and there was the therapy side of things, but the majority of that funding went into things like small business loans, education, vocational school, that kind of thing, like giving people that purpose. I think that's the thing. For me, I didn't have a purpose, like I was just, I was like a houseplant, I say, like I really didn't have anything going on. And I think, there was parts of therapy that I found helpful, But really, more than anything, was like having something that gave me fulfillment and like something to work towards. Like that was the thing for me. And I think for a lot of people, like that's really what we should be focusing on. And I do think that people can like start working towards that while they're still using, or like, still struggling with that, but it gives somebody the means to like start taking a different path, like it's easier to stop having like a desire to continue using or using chaotically if you got something going. You got that statistic?
Yeah, so it was approximately 1 in 10 after the decriminalization. It plummeted to 5 times lower than the EU average, and it stands now at 1/50th. That's 1 out of 50th of the United States.
Yeah.
Rate.
Not surprising. So before decriminalization, 1 in 10 people addicted to heroin. After decriminalization, a 50th of the people in the United States that are addicted to heroin are addicted to heroin. In Portugal, that's pretty wild. So yeah, I think like those are really poignant points to kind of touch on, is like having that other side of
from what I've heard, at least in terms of opioids, some of the more successful recovery programs are ones that include a strong element of resocialization purpose, giving people something to do. Because without that, I mean, what do you have?
Right.
And then it goes back, though, one of the first things we spoke about, the stigmatization. That in our society still, even with all this in the news and all we're talking about, it's still considered by many, it's just it's a moral failing. Snap out of it. Mm-hmm. And what's particularly concerning is we see a lot of that in the physician community. So you got people who are highly educated, skilled, considered these pillars in society, doctors, who still have those views. One of my physician colleagues mentioned recently another physician's family who she treats. All right, the daughter of this other physician in the community has been having a lot of problems with drugs and alcohol, but he doesn't want to put her into any type of program per se. He doesn't want to recognize, she's just going through a stage. And this is coming from a physician who's afraid of putting the stigma on his own child, right? So when you hear stories like that, we still have a long way to go. And I think going back to the initiative that we put together at the Palm Beach County Medical Society, one of the areas is teaching fellow physicians the importance of addiction as a medical disease and not just a moral failing.
Right. Okay. So would you say you've seen, colleagues, other physicians, like, obviously have those stigmas? Would you say you've seen it affect the way that they treat their patients?
Clearly, some of it I've seen directly, some of it I've heard second, third hand. Even you hear stories, particularly in the emergency department, where a lot of overdose cases will be coming in, and they become kind of hardened, the whole ER crew. Oh, it's just another addict. They'll get him in, get him out. We don't really care what happens to this guy. And there's a lot of that attitude throughout the whole system. Now, we might understand, it's logical because these are medical people who may be overworked, overstressed, and they just see the same people coming in and out all the time. But their particular bias isn't helping to change the situation. And surely, if it was a friend or a family member that came in, they probably would have a little bit different perspective on that.
Yeah.
And there's simple things that we can teach to the physicians. First of all, the simplest one of all, a person's not an addict. A person is an individual who suffers from addiction. Right. So that simple concept there, even that goes a long way in terms of putting a message out to our medical community.
Person first language, basically, like not labeling that individual as what they are, but, just identifying an issue that they struggle with, right?
Yeah, absolutely.
Okay.
And then you extend that to all other levels of society. We still have situations where people don't want to hire you if they find out certain things in your medical past. If you had a heart attack or cancer, maybe they're not thinking so much that way, but this guy was treated for opioid use disorder.
Right.
We don't know if we want this character coming in here. So therefore, people tend to lie, not put these things on the applications.
Right.
We see that in the medical community. We get doctors who have had, say, licenses suspended, went through recovery process. They have difficulty getting back into the community. Now, I did run across a physician recently from Tampa who runs a big medical practice, and he goes out of his way to hire physicians in recovery. So we had an interesting conversation.
That's cool.
So that's like, really cool that people are going to be that open-minded. He says, giving these people a second chance is critically important.
Right.
But because there's so few situations like that, you'll have, even amongst physicians, you'll have doctors who are getting into stuff they shouldn't be getting into, and they don't want to admit it, or they don't want to seek treatment because they're afraid it's going to permanently go on their record.
Right.
They will lose their license. Even if they are able to get the license back, it's going to be tainted. It's going to be all over the internet. People are not going to be wanting any part of it.
Mm-hmm.
So this is a very big task. We talked about how there's so many doors. You open one door, there's like 10 more doors there. This is just one of those many ones in terms of destigmatization of the whole process. But I think just recognizing that these issues exist, if we can begin to chip away a little bit at it and just make an incremental step in a good direction, that we have to be kind of pleased with that.
Yeah. So are there anything that you can think of, or something that you are already doing to kind of work on reducing that stigma in the physician community, or just in general?
Well, we have, through our task force, let's not call it task force, through our opioids initiative, one of our major commitments is education for the healthcare community, education for physicians. And we have different units that we're working on, and we put them out there on the internet and in terms of continuing medical education programs. So one of the focuses in this year is going to be a series on reducing the stigma of addiction. Okay. So that's certainly going to be out there. We have also a series for physicians. We have a series of podcasts, Physicians in Recovery, openly talking about their stories. And we're working with a few of those physicians to develop guidelines to put out there so doctors can recognize in themselves or in their colleagues some of the early warning signs. So this, again, just raising awareness, putting the information out there, hopefully can take us in the right direction. Now, as part of that, we also, we're going to be continuing a series for physicians to listen to about how they can specifically approach patients with less judgmental. I mean, we're always going to be judgmental in some part. We're humans, right? But less judgmental, more compassion, particularly in this arena. And I think a lot of people, a lot of my colleagues are perfectly able to do it. They just need the tools. Mm-hmm. It just needs to be presented to them. The knee-jerk reaction is bad now. They go, oh, another one of those patients. Yeah. We need to just kind of ramp it up, educate them, say, come on, this is just another medical illness. We have ways of treating it. These are some of the tools to how we can treat it. And let's take a step back and not be so judgmental.
Yeah, absolutely. I mean, it makes sense, those stigmas and biases are ingrained in really all of us from a really young age. But education and information and just giving people some other way of looking at things can often go pretty far in that regard, and trying to reduce those stigmas, I think. Is there a harm reduction component to any of those the classes or anything like that?
Well, we've been a strong advocate of syringe exchange programs through our initiative. We've helped to move the issue more quickly here in Palm Beach County. And I think amongst physicians, there's very few who would question the value. There is plenty of value in a syringe exchange, reducing the infection rate right off the top, but it's an entry point for people who would normally not be part of the traditional medical care system.
Mm-hmm.
So we can bring people who are literally many on the streets coming in as offering opportunities not just for clean needles and to reduce their infection rates, but opportunities for screening for HIV, for hepatitis, and screening for other things that might be a problem for them. And for us to allow these individuals, again, who normally might not trust the traditional medical system, to come in and see that we're on their side.
Right.
We're there to be with them. And our goal is to bring more physicians into this arena. We're bringing people who will be part of the wound care program that we're layering in with the syringe exchange. We also want to educate medical students. So, this whole initiative started with group medical students from the University of Miami. So we're certainly working closely with the University of Miami medical students, with FAU medical students are very interested in being part of it. So I think by exposing doctors early on in their educational process to some major harm reduction strategies.
Right.
And also at the same time, exposing them to opportunities to destigmatize the feelings towards drug use and addiction. I think we have a lot of possibilities there.
Yeah, definitely. I mean, like, that could be huge, just like getting that early on, like having that kind of approach, or like being able to, the harm reduction strategies and like the implementation of things like wound care and syringe service programs, like those are super important, but also like just the approach, like approaching somebody like with their interests, their autonomy in mind, and, not having these certain strings attached or shaming them, like strings attached to getting services, or just like having them feel shamed or stigmatized, like for seeking services while also being a drug user. Like that can go a long way in just improving the health of the community in general. And also like getting people linked to services that maybe otherwise they wouldn't have.
Sure. And from a medical perspective, as I told you, I've been involved with medical ethics for a long time, chairing the councils for both the state and county medical society over the years, and in teaching medical ethics at various levels. And the tenets of medical ethics, there's 4 of them, but we start with, as you've referenced several times, autonomy. We have autonomy, that an individual, a patient, has the right to choose what they want to do or choose what they don't want to do. So whether it's taking drugs or not taking them, or taking a certain approach to get off of it, these are decisions that you don't want to force on a person.
Right.
But it also goes with what we call informed consent. They have to understand what the choices are. So sometimes I think what happens, there are challenges as a clinician. You say, well, this person is crazy, or they're out of their mind, or they don't understand the choices. So we need to kind of force some of those choices on them. But that being said, there are many, many people who do understand the choices, and we have to recognize that. And as fellow human beings and as physicians who are adhering to the ethical code, you have to grant the patients their autonomy. Along with that, we have beneficence, which is to do the right thing, to do what's good, and non-maleficence, which is to do no harm. So these are all things that we have to put in balance. And I think that ties in very closely with the goals here in the whole opioid epidemic in Palm Beach County, and what the medical community wants to and needs to do as we move forward.
Yeah, absolutely. Those are the same 4 tenets as like social work and human services, interestingly enough. I mean, it kind of goes into the same thing, but, giving people all of the information, like that's kind of what I picked up on like the, autonomy side of things, and then the informed consent side of things. Like people need to have the right to like make their own decisions, but there's nothing wrong with giving somebody all the information that they need to make the best decision for themselves. So yeah, I think that all 4 of those things play a big role in somebody like treating somebody with a substance use disorder the right way, but it's not always carried out in that way. I mean,
Exactly.
in my own experiences and many others.
We mentioned there's 4. I only described the first 3. The fourth one is called justice, which is kind of a nebulous concept, but it basically means having equal or equitable access for all. And this is another huge challenge, because finding the funding for these things, getting the education out to different segments of the community is a whole nother challenge. But that's important, because we're not targeting just one narrow group of individuals. It's available to all persons in the community. And I think we have to actually work hard to do that. And I know, just looking at the syringe exchange program, we're exploring different neighborhoods so that we're not just in one location. And the fact that we have a mobile unit, very few of the facilities across the country or across the state of Florida are able to say that they have a mobile unit. So we're able to take these services into the communities where they're needed, as opposed to saying, well, you got to come to that place at this time. And in healthcare in general, and certainly this all falls under the umbrella of healthcare, you need to make things as accessible as possible, because people don't always have transportation. People don't always have flexible hours, et cetera, to be able to access the different things that we're trying to do.
And that's where, if something like in terms of mental health, like that's where telehealth could come in, but having that mobile unit, like for the things like HIV testing and, wound care, like these direct services, like that can be really huge for a lot of people. Like in Belglade, is that kind of what you're referring to? Like areas like that? You guys planning to go out into the glades?
Sure. I believe we're looking to go into Pahokee and some of those other communities, which is remote from this part. Those far western communities is like a whole different world. And it's not so easy to get from there to downtown West Palm Beach. With COVID and the vaccines, and they were early on, the testing, the vaccines are doing all of this at Publix, but there's no Publix.
No Publix. Closest is Waxahachie. It's crazy.
So you have to dig deeper so that we can appreciate that fourth aspect of the ethics, the justice, kind of like making these things available to as many people as possible.
Yeah, absolutely. I mean, you can see injustices like on the healthcare side of things, on the drug policy side of things, just like the disproportionate, sentencing laws for crack cocaine versus cocaine hydrochloride. It's very different, and you're going to get a lot higher of a sentence for crack cocaine than cocaine hydrochloride. And that's really just based on like crack being commonly used among minority and impoverished communities, and cocaine being probably pretty common in places like Palm Beach Island, as well as, like anywhere that people tend to have more money oftentimes that are using like cocaine hydrochloride versus crack, and like there's disparities there. So would you say, like, do you have any thoughts or feelings, opinions on the way drug policy, societal views on drugs have impacted people who use drugs, like maybe in your own experience or just your own views?
Well, the last comment that you made is a very obvious and something that our society should be embarrassed about. The fact that when this was a problem in the inner city Black community, it's like lock them up, who cares? Right. Suddenly when it hit white middle class and white upper middle class families, suddenly it was an opioid epidemic.
Public health versus a public nuisance.
Right. So the fact that it had to come to that is kind of shameful, but be that as it may, at least moving forward, we've kind of identified that is a situation. What was the question again?
No problem. Like if you have maybe any views or thoughts on how the drug policy in the United States, or just like societal views on drugs and drug users, have shaped the experiences of people who use drugs, or maybe the experiences of society in general just surrounding drug use.
Well, I certainly think there's a lot of hypocrisy, because you even have policymakers who set certain standards, but then they go off and do whatever they want on their own. I remember attending sporting events that was raising money to fight drug abuse. And they had all these big celebrities there.
Mm-hmm.
And these guys were like going up to their rooms and doing all kinds of drugs because this whole point of view, well, it's not me we're talking about. It's the rest of those guys
Right.
out there that we need to. So that is a peculiar hypocrisy that goes on out there.
Mm-hmm.
I think we're moving in a very positive direction, though. There's a lot of work still to be done. But if you look at where we were 10 years ago or 50 years ago, we're much more open on a professional level. There's a great deal more sensitivity to the whole problem. And I'm hopeful and optimistic that we can move in a pretty good direction.
I am too. And I think having conversations like this is like a big step towards that, or at least, it is moving in that direction. I think it's just like being able to have conversations about these things that maybe not a lot of people are able or willing to talk about. And just like kind of the whole series that we're doing, I think like these different experiences may not be like what everybody is used to hearing and seeing. And I think that can go a long way in like starting to kind of divert that stigma. So would you say like you've seen that kind of starting to change in your area with your colleagues, your field?
Yeah, absolutely. Because people are beginning to recognize this as a real problem. Opioid education is now a required 2-hour course that we have to take every 2 years. A lot of the courses are kind of dull and boring, and they just talk about the rules and the laws, but at least it's getting out there in the arena and people opening their eyes within the medical community and realizing this is something that we need to deal with. And like you said, we're having more and more conversations. It's not an overnight cure or an overnight change.
Yeah.
These are incremental steps. Again, chipping away at some of the old biases. And I'd like to think amongst my colleagues, the vast, vast majority want to do the right thing. We took the Hippocratic Oath to do no harm and to help people who are in pain and suffering, which includes people in the opioid arena. And again, I'm hopeful and helpful that we are going to be moving in the right direction there.
Absolutely. So is there anything else, any other thoughts you'd like?
Well, one thing I was just thinking about, we still have an area where there's a lot of frustration about what we would call this recidivism rate. I had a patient in last night who was very, very upset because her daughter is in and out of different programs. And this is a woman herself who's in recovery and understands the whole arena, and she's worked with recovery programs, but she's so frustrated that within her family, she has this problem with her daughter. And it's this area is certainly an area that we really need to look into, but those individuals who just get trapped in that cycle, this repetitive cycle, what can we do to break that? And I was asking her, we were talking before about MAT. She goes, oh, she's been on that. She goes, the last time, she would take the Suboxone one day and then she would take the oxycodone the next day. So you hear all these kind of stories, and I'm thinking like, wow, what can we do to make a difference here? Clearly our job is not finished yet by any means. And again, it goes back to there's so many components. If we can save one life, or we can help one person, we've made a difference. And I think we have to just console ourselves with that. But it's frustrating for me to hear stories like that from people who know which numbers to call and they know who to turn to, and yet they feel this hopelessness in their life. So I don't have the answer. I don't know if you do. Okay. But when I see that, I realize that there's still a lot of work to be done. I told her I will call her and we'll talk about this and see what we can do to make a difference, because maybe I can learn something from this particular example that we can apply in general to other people down the road.
Right. Yeah, that's definitely common thing that I hear about. I mean, it's common experience, unfortunately. I don't have the answer either. I wish I did or anybody did. But I would, maybe my first thing that I would say is just asking the daughter, what is she wanting to do? Like, if it's just the point, like if somebody isn't ready to stop using or they don't want to stop using, putting them into a treatment program or getting them on MAT, like, maybe the MAT could reduce their use and that could be a step towards some positive change. But like, it really comes down to where the person is at and, their own motivations. My kind of first go-to is just asking them, what are they trying to do? What are their goals? And then, if somebody isn't wanting to stop using, just harm reduction services, make sure they have naloxone, Narcan, whatever they need as far as safe use supplies. I know that's super hard in a position of like a mother or even a family member in general, like, because I can say, like, if I were in a situation where a family member was, using all of the things that I know and all the approaches that I take to anybody else that I, work with, have the tendency to initially go out the window just based on like my own emotional reactions. And that's just like what's kind of, again, been ingrained into us. But I think like oftentimes that's just forgotten, like in terms of that part of the approach is asking that person, like, what do they want to do? What do they want? Are they wanting to stop? Are they wanting to, try a different route? A lot of times we forget to ask those questions.
Which Austin goes back to what we were talking about before in terms of autonomy. Right. As a human being, does a person have the right to say, I want to keep doing the drugs? Mm-hmm. Who are we to tell them you can't do that?
Right.
If this is their personal decision.
Yeah, I agree. Just help them stay safe and give them all the information that you can to help them make, if not the best choices for them, the safe choices for them, and really they're the only one to say what the best choice is. So I think that's an important point and, something that needs to be acknowledged and discussed and kind of remembered maybe more than we often tend to.